Good afternoon, everyone, and welcome to today's program. My name is David Applegate. I'm the Director of State Policy at the Kennedy Forum, Illinois, an organization focused on eliminating stigma and discrimination against people with mental health and substance use disorders. Our conversation today will focus on telehealth and its ability to increase access to mental health and substance use disorder care. While telehealth is not new, its usage as a means to deliver and receive services has increased exponentially since the onset of the COVID-19 pandemic, and it has been vital to maintaining access to care the past 9 months. We must look forward now at how telehealth can be further leveraged to grow access to mental health and substance use disorder care, particularly in underserved communities and in populations facing inequitable access to care. Before I introduce today's panelists, I want to cover a few housekeeping items. We will start with some quick presentations from a couple of our panelists, and then we will move into a panel discussion and question and answer. Throughout today's conversation, you can input your questions in the question and answer box, which can be found at the bottom of your screen. We have a lot of people in attendance today. We're going to do our best to answer as many questions as possible, but if we don't get to your question today, please do not hesitate to reach out after the conversation. With that, I would like to welcome and introduce our panelists. So first, we are excited to be joined by two members of the Illinois General Assembly, both of whom are champions for people with mental health and substance use disorders in the Illinois House of Representatives. Representative Deb Conroy has served in the Illinois House of Representatives since 2013. She represents the 46th House District located in DuPage County and is the chair of the House Democratic Women's Caucus. Representative Conroy has long been an advocate for people with mental health and substance use disorders, and we are extremely fortunate to have her as the chair of the House Mental Health Committee. Representative Maurice West has served in the Illinois House of Representatives since 2019. He represents the 67th District in Rockford, Illinois. He is an ordained minister and has an MA in professional psychology. Representative West is also a member of the House Mental Health Committee and is a committed advocate for the needs of people with mental health and substance use disorders. Additionally, we are also joined by representatives from Illinois' community of behavioral health providers. Raul Garza is the president and CEO of Aunt Martha's Health and Wellness, which is 35 locations and 23 community health centers spanning 9 different counties in Illinois. Mr. Garza is a passionate advocate for underserved and vulnerable communities. Under his leadership, Aunt Martha's has embraced the concept of value-based care, established many collaborations to serve special populations, and has emerged as a recognized leader in integration and care coordination. Dr. Wanda Parker is the Vice President of Clinical and Therapeutic Services at Aunt Martha's and is a certified addiction counselor and professor for graduate psychology and addiction. She has over 20 years of experience in behavioral health, having worked with many at-risk populations such as children and adolescents, pregnant women, veterans, and the forensic and medically compromised populations. Finally, Leah Daniels is a director of health policy and finance at the Illinois Health and Hospital Association. Leah provides leadership on a range of healthcare policy and reimbursement issues at IHA, including telehealth, behavioral health service, and workforce needs and social determinants of health. So Leah is going to kick us off today with a brief overview of telehealth in Illinois. So I'm going to hand it off to her right now. Leah, thank you for joining us today. The floor is now yours.
Thank you, David. James, if you want to flip to slides. Thank you for having me. I was asked to talk to you today about telehealth law and policy, given the dramatic changes the healthcare delivery system has undertaken during the COVID-19 pandemic, as well as access and equity opportunities demonstrated by this delivery modality for behavioral health. So I'll start there, that telehealth is a modality or a use of digital information and communication technologies to access healthcare services remotely and manage your healthcare. Next slide. To help ground the discussion, I've listed different telehealth policy considerations on the slide, although I won't get to all of them today. It's only about 10 minutes. What we will touch on are coverage and payment, as recent implementation of emergency coverage and payment for telehealth has temporarily reduced social, economic, and environmental barriers to care like transportation, childcare, and insurance costs. Next slide. I want to provide some background on current pre-pandemic telehealth policies. After all, current policies are temporary, and this is what we would revert back to if action is not taken by the General Assembly. Illinois has historically been minimalistic in its approach to telehealth law. This creates some concern for liability, as well as coverage and payment concerns from either providers trying to decide what services to offer, or individuals trying to understand what healthcare services are covered and they can actually access. To To simplify, I'm going to compare services delivered via telehealth to in-person services and state whether they are treated equally. Even before the COVID-19 public health emergency, 36 states had telehealth coverage parity policies, and 16 states had telehealth payment parity for commercial health plans or private health plans regulated by the Department of Insurance. Illinois did not require either of these, coverage or payment parity. Telehealth coverage itself is not required by the Illinois Insurance Code. If commercial health plans regulated by the Department of Insurance choose to cover telehealth, they are only required to ensure copays or deductibles are not higher than those charged for in-person services. For Medicaid, 21 states had telehealth coverage parity policies, and 28 states had telehealth payment parity. While Illinois offers, and this is all pre-pandemic, obviously everything has changed a bit, but even then we were a bit behind. So there's limited Medicaid coverage of facilities and providers, for example, inpatient hospital settings, skilled nursing facilities, and assisted living facilities are all excluded from telehealth reimbursement traditionally in Illinois. There are also limited settings where a provider can deliver a service and where a patient can receive a service for Medicaid. Rules and policies have also not been written or promulgated on a series of small Medicaid telehealth expansions that were supposed to be effective in 2019. For Medicaid behavioral health services, psychiatry is actually separated from other medical services within rules, and group psychotherapy is specifically excluded as a service for reimbursement. So there is the issue of potentially treating these services differently under telehealth coverage. Next slide. So on this slide, you'll see the governor's executive order on telehealth and a federal press release announcing dramatic increases in telehealth utilization as a result of coverage expansion. On March 19th and 20th, as you all probably know, Governor Pritzker and the Department of Healthcare and Family Services temporarily lifted longstanding barriers to access via telehealth by requiring commercial health plans and Illinois Medicaid to allow for the delivery of clinically appropriate, medically necessary healthcare through electronic or telephonic means and reimburse providers at the same rate as in-person visits. Insurers were also required to waive cost sharing for all services delivered via telehealth and lift restrictions that prevented patients from receiving care in their homes. Under the Medicaid emergency rules, there's broad coverage of behavioral health services to allow delivery via phone or video interaction, which is very important for patient access and equity, as not all patients have access to technology with video capabilities. On the federal side, and with Medicare, the big changes were to allow patients to be in their home or in any other setting to receive telehealth services. There are no geographic or location restrictions anymore. Pay providers at the same rate for telehealth services as they do for in-person visits for all diagnoses, not just those related to COVID-19. Relax requirements so that patients do not need to have an existing relationship with the provider who is delivering a service. Waive or reduce cost sharing for certain telehealth visits. They waived sanctions and penalties for healthcare provider privacy rules to allow them to use everyday communication technology, including Skype or FaceTime for Medicare. Relax cross-state licensing requirements, allowing states to apply to the federal government for a state licensing waiver. So by this, I mean healthcare professionals who are licensed in one state may provide services to a patient in a different state. In 45 states, DC and the territories sought these waivers to varying degrees. So there was definitely demand. Finally, Erisa group health plans, also known as employer plans, a large number of private plans that are regulated by the federal government must cover telehealth or other remote services without cost sharing or other medical management requirements like prior authorization, but only for certain COVID-19 diagnostic tests. Also, high deductible health plans may cover telehealth without a deductible, but these temporary requirements and allowances are very limited in scope and really don't compare to what Medicare, Medicaid, and frankly, Governor Pritzker took action on earlier this year for Illinois health plans. Next slide. So let's say we want to look at access and equity across Illinois and how the population could benefit from telehealth as a pathway to service access. One measure that allows us to understand access barriers are federally designated health professional shortage areas. These are designated by the Federal Health Resources and Services Administration and used to identify areas, population groups, or facilities within the United States that are experiencing a shortage of healthcare professionals. Measurement criteria for mental health professionals are listed on the slide, but I won't be referring to them. I just wanted to show you how it is a complex measure. Next slide. In the map on this slide, counties shaded in medium or dark blue indicate a partial or full mental health professional shortage in the region. Of Illinois' 102 counties, you'll notice a vast majority have professional shortages throughout the full county. During the pandemic, telehealth has been used as a gateway to service across the state and can help to continue to address these access barriers in the future. Next slide. This next slide segments mental health professional shortage areas by metro and non-metro areas. Both images depict shortages in almost all regions, regardless of population density. There's a common misconception that provider scarcity is a rural issue. But in fact, on the south side of Chicago could have the same specialty professional shortage as Redbud in Randolph County, which has a population of 3,700 people. So anecdotally, telehealth has made an impact for busy rural farmers and urban families that cannot afford to take time off work to travel to appointments, not just under the COVID-19 pandemic. So let's shift gears with the next slide on quality. In terms of the quality of health care that patients receive via telehealth, a lot of research has been done and shows that this modality increases access to treatment and providers, while also using digital technology to build therapeutic communities. The Telebehavioral Health Institute featured on this slide has 916 impactful articles in their telehealth reference bibliography. As highlighted on the slide as well, the Federal Agency for Healthcare Research and Quality, also known as AHRQ, released an issue brief this year providing a systematic review of a broad collection of studies on telehealth and patient safety. Among the findings were that the evidence base for telehealth is strong, especially for the remote management of chronic health conditions. Systematic reviews confirm that telehealth improves health outcomes, utilization, and cost of care for a host of chronic diseases, including mental health conditions. So that evidence base is there. And for non-urgent complaints in primary care settings, diagnostic accuracy and the likelihood of diagnostic error appear to be roughly comparable in telediagnosis versus face-to-face encounters. Next slide. So let's look at how healthcare quality can intersect with access and equity in care. Based on the broad systematic review highlighted in the last slide, AHRQ found that specialty telehealth consultations likely reduce patient time in the emergency department. A local example is at Unity Point Health, the Robert Young Center. The provider has found that 70% who use the telehealth-based mental health assessment service that they provide at unaffiliated hospitals were able to transition to a lower level of community-based treatment, decreasing unnecessary hospitalizations and associated transfers by ambulance or police departments. This also ensures patients receive care at the right time and in the right setting. AHRQ also found that remote consultations for outpatient care are likely to improve access and clinical outcomes, psychotherapy being an example. Next slide. So beyond quality of care, telehealth has helped drive a reduction in the rate at which patients missed appointments and demonstrated increased care plan adherence, improved chronic disease management, and downstream cost savings. Although I will point out that the pandemic has demonstrated cost reduction or neutrality in the near term as well. An example of these, the reduction in missed appointments would be baseline no-show rates specifically for psychiatry services is between 19 and 22% of appointments, while MD Live reports no-show rates of only 4 to 7% for its behavioral health telehealth visits. Based on a recent IHA survey this year, over 70% of Illinois hospitals that responded also found that telehealth has helped drive a reduction in the rates at which patients missed appointments. This decrease in missed appointments demonstrates the potential to improve care, but it also shows us that social determinants of health can act as a barrier to accessing in-person care. Telehealth can remove access barriers created by social determinants such as lack of transportation, geographic isolation from healthcare professionals. And then just going along with that, as a final example, the Federal Centers for Medicare and Medicaid Services estimated that telehealth saves Medicare patients $60 million on travel. So the agency even conceded that these estimates tend to underestimate the impact of telehealth. Higher projections estimated $540 million in travel savings by 2029, and these figures were compiled before utilization increased under the pandemic. So with that, thank you for your time today, and I look forward to hearing from others on the panel.
Great, thank you, Leah. That was a great start to the program. So now I want to hand it off right away to Raul Garza from Aunt Martha's before we dive into our question and answer. Raul?
David, thank you. And let me just say that we're honored to have been asked to participate and really appreciate what Leah laid out. I think a lot of what I'll talk about really folds into that coming from a provider perspective on the ground. So if we can go to the next slide. I thought this slide was interesting because it shows what was the current state of telepsychiatry before the pandemic, and you could see that about 30% of the psychiatrists in the country were actually using telehealth as an intervention modality, and how that's changed since the pandemic is now that's increased to 98%. So that's about 172% increase in just the last 9 months. So, I mean, that's a pretty profound statistic considering, how psychiatrists have been able to pivot to get the people that need the care. So I thought that was interesting. Next slide is more specific to our experience. So just a little bit about Aunt Martha's for those who don't know us. It was almost 14 years ago that we actually pioneered telepsychiatry in the state of Illinois. And the original thought was really to get to communities that could not otherwise access a psychiatrist. So the work was centered or focused on central and southern Illinois. And then I think over the years, as we became more mature and working with the technology, we really saw it more as a tool, even to get to suburban and urban areas where there was a lack of psychiatric capacity. What these slides tell you, and I'll talk to the first one on the left, is it gives you a sense of what the growth has been. And let me just say this, the universe of patients we serve with a mental health diagnosis is about 10,000 patients. And I think we're at a point where we see over 70,000 patients and we touch over 105,000 lives, including all the programming that Aunt Martha's provides. But 10,000 of which over 3,000 are done through telepsychiatry. Probably about another 500 to 1,000 are actually patients who come into the clinic to see the psychiatrist. And then about 6,000, a little bit over 6,000 are actually seen in the primary care setting through a collaborative care model. So we're really pushing the most acute patients or that have the greatest diagnosis with a psychiatrist. And so you see the growth that we've experienced from 2019 to 2020. And most of that obviously is driven by what we've seen happen with the pandemic. And then the slide on the right gives you a sense of what the typical experience was on a month-to-month basis, which was around 1,000 visits we were doing through telepsychiatry. And now with the expansion of telehealth, which also includes teletherapy, you see how that number has grown. And embedded in the telehealth that's not telepsychiatry or teletherapy are many of those mental health patients that have a lower acuity mental health diagnosis like low-level anxiety, depression. So that's our experience, just in a snapshot that you can see what's happened over the last 9 months and as it compares to the previous 3 years. We'll go to the next slide. And so this is, I think, pretty interesting as well. You could see that in 2019, we had a little bit less than 400 new patients coming into our telepsychiatry. And obviously that doesn't reflect the demand. I mean, there's a lot more need than just that, but it's it's about our ability to, create more capacity. And you see, as a result of the pandemic, we were able to do that. A lot of that through teletherapy and really being able to manage a lot of those mental health diagnosis between the primary care provider and the therapist. My colleague, Dr. Wanda Parker, will be able to tease that out, I think, as we get into the Q&A session or section of this discussion. But you can see that that increase is well over almost 370%. And then something you might be asking yourself is, well, wow, if you had that kind of growth in the number of patients, why isn't the growth proportionate with telepsychiatry visits? And that's because a lot of those people have come in over that 9-month period as new patients to us, and they've only been able to come in, having received one visit. So I think that speaks also to the point about, the capacity tightening in terms of, being able to provide more visits, although we're taking patients in. And again, a lot of that we're able to manage at the PCP level, the primary care provider level. The next slide, I think, is a really good one when you look at what the top 5 most prevalent diagnoses were before COVID-19, and that's in ranking order. And then you see what we've experienced over the last 9 months since the pandemic, and what's shifted is major depressive disorder. And I don't think that should be a surprise to anyone, as a result of the environment that we're all living and operating in. And you can see how the other diagnoses follow in that ranking order. And then finally, some anecdotal on the next slide, well, let me say this. I think Leah touched on this, which the first stat makes me a little nervous because it means we're double what the no-show rate is on what you're showing average. And as I was thinking about that, I thought, well, I also know we're working with highly acute, mostly patients, and I think probably the other information that was illustrated was more of an average. But yeah, so it's 40% previous. When you talk about in-person therapy, and then as a result of the expansion of telehealth, again specific to teletherapy, that has reduced by 88%. Bringing it down from 40% no-show rate down to 5%, and that matters. I mean, what I would say is over the last 9 months, I think we are creating the clinical argument and also the business argument why this makes sense. Why this needs to be sustainable going forward once we're through this period. And then finally, the last slide, which I think Dr. Wanda, if you want to jump in, because you're both, in the trenches, seeing patients as well as administering the work overall system-wide at Aunt Martha's, and you could maybe speak more personally to what patients are saying about the telemental health services, which I won't read all those to you. You can see those, but also what our clinicians are saying about it. And the most important thing is that I think generally both people, or both types of people, are staff and patients, feel safer as a result of this. And I think they feel a greater sense of confidence around privacy and things like that. So Wanda, I don't know if there's anything you want to add to this particular slide.
Yeah, I think for the most part, patients have been very appreciative of us prioritizing their mental health and substance use issues, and that it didn't fall by the wayside and COVID take prevalence, that they still have access in a way that they didn't before. Talked about the no-show rate and cancellations. Those things reduced tremendously because some of the barriers is finding transportation to and from, and finding transportation in the age of COVID. Some people who may have been willing before to give you a ride aren't necessarily willing now because of social distancing. So it really eliminated that. And I think that even for those who may have been somewhat engaged, became more engaged because of access. So we saw an improvement on both levels.
Right. And so I wanted to keep this very concise because I wanted to save time for the discussion. So that ends our presentation.
Great. Well, thank you so much, Raul. That was excellent. Thank you both to Raul and Leah for that great kickoff to this conversation. I think it really frames what we want to talk about today. So with that, let's start the discussion. So thank you to all the audience members for submitting some great questions. I want to start with a more general question for our panelists. So prior to the COVID-19 pandemic, our communities were already facing rather profound challenges related to mental health and substance use. And it's become increasingly clear that in the past 9 months, that stress from the pandemic has really exacerbated these challenges and issues. So Representatives Conroy and West, I want to start with you. From your perspectives as state legislators, and really especially as members of the Mental Health Committee in the House, what have you seen and what have you heard from your constituents with regards to the mental health and addiction crisis in our communities? What are the challenges that you're hearing from your constituents? So I will defer to Representative Conroy. Do you want to go first? Or?
Sure. I would say so much. We're hearing so much from people, but the thing that strikes me the most and the hardest is how many people I'm hearing from about children at such young ages that are showing serious anxiety, almost debilitating anxiety. I think this is something that is a whole new layer to what we've been dealing with. And the other issue that I think is new to the COVID crisis is the amount of first responders and medical professionals that are telling me we are going to have overwhelming PTSD coming out of this pandemic. So I would say besides the things that we've already dealt with and not having had enough access to care for, the crisis that we were in before the pandemic, these are the two things that I think are the most startling and concerning to me currently in my district.
And Representative West, what are you hearing in Rockford?
Yeah, I'm hearing the same thing, and that Leader Conroy mentioned. And even to go further, I've had 3 virtual town halls with my constituents on mental health. And we had great conversation on the fact that we're seeing that mental health is just as important, or sometimes even more important than physical health. I can't get physically better until I'm I'm ready to do it within my mental state. But even, the common cold, a sore throat, and people are thinking the worst because of the pandemic that we're in, and it's taking a toll on people and they don't even know it. They say stress is a silent killer. And people are being stressed out, not just by losing their jobs, not just by what they're hearing on the news and the polarizing conversation that you hear on the news, but can I keep my family safe? I have family members who have are compromised immune system, compromised lungs. Can I keep them safe? And I'm an essential worker. So people are stressing things and not really knowing that it's weighing heavily on their mental well-being as well. And so, but the beautiful thing I feel is that we're having these conversations now, and people are more open to these conversations, and they're open to taking away the stigma around mental health, especially amongst the Black and Brown communities, especially the Black and Brown communities who are religious. It's not just let's pray about it and go to bed. It's about let's seek wise counsel amongst those who are among us. And the narrative is changing. So I'm thankful for that, but we still have a lot of work to do.
And Maurice, just to add to what you were saying, I think what I've seen is that telehealth has become a powerful tool in terms of removing more of the stigma. It's been amazing to see how many more people are willing to talk about the fact that, they're getting help. It's much more acceptable for whatever reason through a telehealth provision than it is through the older.
Right. And I love how, even Hollywood is getting on board with it. I don't know if you guys watched This Is Us, but the last couple episodes, Randall was doing telehealth, telepsychiatry with his doctor. And so it's becoming something that's a common theme in our society.
So that's a great transition. And so it's been nearly 9 months since Governor Pritzker showed some really profound, great leadership by taking action to require health plans to cover and reimburse telehealth equitably throughout the pandemic. So I want to go to Raul and Dr. Parker first with this one. You know, Aunt Martha's works in communities representing many diverse populations in candidly in different corners across the state. And I understand you've been using telehealth for years, even prior to the pandemic. So, you know, Representative Conroy mentioned stigma reduction, and I guess I would like to hear from your experience. What would you say has been working well? What would you identify as some of the key benefits and advantages of using telehealth to deliver behavioral health care?
Yeah, so I'll defer to Dr. Parker because, as I said, she's in the trenches. She's talking with the patients. She's talking with our clinicians. Dr. Parker.
So I think that what's been really important for our patients is that they have relationships with us. And we were able to maintain those relationships going from in-person to telehealth. Also, I think the reputation of us in the communities where people have difficult time accessing not only healthcare, but other things, you know, some of the things that Representative West and Conroy mentioned that are stressors in those communities. And so we've seen other people who maybe weren't primarily diagnosed before with mental health issues or substance use issues accessing services because of the ease of access. I mean, I think that people were stressed before in a lot of the communities that we serve because of the stressors that we talked about, systemic racism, access to COVID testing initially when we saw on the scene, which I think was one of the reasons why we were so committed to offering COVID testing as well. So I think we actually have expanded our relationships with the patients that we had, and then some patients that maybe hadn't utilized our services, or to that extent, we're utilizing them now maybe for primary care and mental health and substance use services.
And what I would add, David, just on a broader scale, is that what we learned over the last 9 months is that this has been a large-scale demonstration that really demonstrates the care that is possible as a result of having gone through this experience. So I think the kinds of data that I presented, and I know that's out there in a grander scale, really needs to be studied and really organized in a way that we enter into conversations going forward about what's the sustainability of this. And that's what I think excites us, that this can be much broader or much deeper than even what we initially thought 13, 14 years ago.
Yeah, I think that's a great point. You know, the past 9 months have really kind of provided us with a good test run to show just how impactful all this is, and really the excitement, the potential for this to increase care. And I guess, Leah, do you, from the hospital's perspective, do you have anything you'd like to identify in terms of what you think are some of the key benefits or the advantages of how telehealth has been really useful from the hospital's perspective in particular?
Well, I think from a patient and provider perspective, once you get over the learning curve, it's convenient. You can avoid unnecessary emergency department visits. Yeah. You can be eliminating what some may feel is a stigma with seeking help for seeking help in person for certain types of conditions. We know those barriers exist for some patients, and we want to eliminate them, frankly. Allowing patients to take appointments via telehealth also reduces barriers like childcare, transportation, unnecessarily taking off work. There's an entire economic impact of people having to take an entire day off work to take their child in, for example. Everyone misses everything. And if we can avoid that when clinically appropriate, why not seek those ways to reduce access barriers? In terms of what we've seen from patients, the vast majority of seniors, 91%, enrolled in Medicare Advantage plans this year reported a favorable experience with telehealth. And that was according to a study funded by the plans themselves. This offers us critical insight to the rapid acceptance of technology by a vulnerable and increasing segment of the population. This has been the main issue. We've been worried about whether the elderly will be comfortable with telehealth, and we had a very quick introduction to the fact that no, they're fine and they understand. And in fact, the convenience far outweighs, the technological barriers. Even as in-person visits have resumed just this year past the wave, the first wave, telehealth use has remained at a persistent and significant level. So about 20%, 21%, depending on what data you're looking at, with strong indication from patients and providers that this flexibility to access care really should be maintained permanently in some form.
And so Leah, you mentioned barriers there, and I kind of want to use that to transition to another theme here. Is we've gotten multiple questions that I would bucket as being related to barriers to accessing telehealth. So some of these questions have related to insurance issues, others have related to technology. So obviously, in order for telehealth to actually increase access to care, people must be able to access telehealth itself as an option to receive care. So maybe, I could start with Leah, and then I'd really like to hear from others on this. Is, you have substantial experience working in telehealth policy space, and you've talked about some of these things in your opening. Like, what would you identify as some of the key barriers to providers and patients being able to fully utilize telehealth? And perhaps thinking ahead a little bit, what are some of the policy changes from the past 9 months that have helped mitigate these barriers and are important moving forward?
Well, by far, I would say that post-pandemic laws and rules that are on the books now regarding inequitable insurance coverage and reimbursement for both Medicaid and private payers that are regulated by the Department of Insurance are the greatest barriers we face. The Governor's Connect Illinois initiative, which his administration prioritized and invested in well before the pandemic, is directing $420 million toward strengthening and expanding high-speed broadband, really recognizing that access to broadband is a critical component and could be a barrier in some communities without it, to improving the lives of families and businesses for everything from healthcare to education, frankly. I think there used to be concern about fear of technology, as I mentioned, but obviously current surveys have really demonstrated that we have had this education, this quick education on telehealth, and people are committed to using it, even when COVID-19 may be less of an issue. So what can be done to overcome, I think was your second question, right? I think the immediate mobilization of telehealth programs during the public health emergency would not have been possible without the temporary guarantee of payment and coverage for services. Without legislative action from the Illinois General Assembly, providers will not have the certainty they need to continue to invest in and utilize new care delivery tools. And Illinois residents will abruptly lose access to the telehealth services they've relied on during the pandemic. So payment parity is the linchpin to really removing existing barriers to patient access and provider adoption. And it will pave the way for the widespread implementation of telehealth in the future. After all, providers are delivering the same service they would deliver in person. In 2021, there's a significant amount of change and innovation to look forward to. Our hope is that the permanent telehealth coverage and payment parity will continue to be a priority of this administration and the General Assembly.
For Dr. Parker, a similar question to you in terms of the barriers. What do you see as some of the barriers that patients face in terms of their ability to access telehealth? I think, you often hear of the digital divide, and obviously technology is central to telehealth. But if folks don't have access to the internet, or they don't have access to a computer, or maybe they don't have sufficient minutes or data, how do providers, how do we overcome that and make sure that despite those technological barriers, that people have access to telehealth as an option?
So I think that definitely those digital divides exist, and they can be a barriers for some. I think Leah made a good point with some of the seniors that we thought that they would be the group that would be the most challenged, but they have grandkids and they have younger folks that show them how to use, and we tried to personally utilize a platform that was easy access. But I think we do have to look at how we can have more access to internet services. We have children that don't have internet access to do their homework. So, so when we talk about mental health stressors, that would be one. I think that we have to be able to find ways to fund that, and it's a benefit to all because the insurance carriers have case management and complex case managers that are trying to reach their patients to make sure that they're engaged in services. If they don't have those capabilities to reach them, then I think it really kind of limits that access. The other piece is that it's not just for providing the telehealth visit, the substance use visit, or the mental health visit. It may be for remote monitoring of the patients of chronic conditions, right? Depression is one, depression screening, but also diabetes, asthma, hypertension, all of those ways of being able to improve health outcomes across behavioral health and physical health. So I think that there's a reason for investment at more than one level.
Representative Conroy or Representative West, I don't know if you have anything to add on terms of what perhaps you've heard from your constituents or providers in your communities just about some of the again, maybe the advantages of telehealth, but also maybe some of the barriers.
I think what Dr. Parker was saying is really important in that we have to, and I think this is something that we need to engage the insurance companies into the conversation as well. We need to be able to provide the devices as well as possibly hotspots or whatever needs to be done so that people have the ability to have access. And I think there's an argument to be made that perhaps the insurance companies have somewhat of an obligation to be a part of that solution. I think it's a huge issue, and I think it's something that we need to be looking into. Whether it's iPads or it's some sort of a device, a phone, whatever it might be. We have to make a commitment to making sure that we bridge that gap so that everybody has the ability to do it, because at the end of the day, this is going to bring down costs for insurance companies because they are going to get the care that they need. And if we don't care for our mental health, we can't care for our overall health. And again, parity is super important, whether it's payment parity or whether it's insurance parity. These things have to be priorities for our legislature.
There's an argument to be made as well in regards to the diversity of our providers. If you look like me, you are like me, you get me. So telehealth could make it easier for people of color to find someone else who is a person of color, but at the same time, the question becomes, do we have enough diversity amongst providers? Do we have enough people going into the mental health counselors, psychologists, psychiatrists, into this arena who are people of color? And so that could be either a advantage depending on where you are, or a barrier depending on where you are, especially in rural Illinois. It could be a little bit easier finding a diverse group of professionals in the urban areas, Cook County, DuPage, Will, even my county, Winnebago. But in the other counties, the rural counties, it may not be as the same. But then I question insurance, going back to insurance. Will I be able to, what will my out-of-network, what would that look like? Could I find a person, if I'm in rural Illinois, can I find someone in Cook County who could be my provider without considering me to be out-of-network? So we have a lot of questions to ask and to resolve when it comes to legislating this topic.
Yeah, I think you bring up a good point. Oftentimes I've heard lack of access to culturally competent care as a barrier for folks to accessing medically necessary treatment. So that's access to providers who perhaps they share a patient's racial, ethnic, or linguistic background, or perhaps there's providers who specialize in delivering care that is sensitive and empathetic to a particular culture and lived experience. So I think you bring up a good point. We do need more diversity in the workforce, but I'd be curious too, from the provider perspective here, is do you think that telehealth could help in this, increase access to culturally competent care? Do you think there's any potential there? And I guess I'll open that up to either of our provider representatives on the call, if either one of you jump on that first.
Yeah,
I would say,
go. Go ahead, Wanda. Go ahead.
Yeah, I would say definitely we've seen that. What we do is a lot more matching that since we don't have some of those geographic barriers. So we have a client who needs mental health services, but also has some domestic violence issues, and we can match them with one of our providers that is a licensed clinician, but also certified in domestic violence. The same with co-occurring issues matching Spanish-speaking clinicians. And so since we don't have this geographic divide, we're able to closely match so that they get their needs met.
I was going to say, first let me say I appreciate your comments, Representative West. Depending on the studies that you look at, it's anywhere from 2 to 8% of the leadership in the healthcare systems across the country are people of color. That means it's not diverse, and there's a correlation between that and the inequity in healthcare. And in order to have equity in care, that can't be achieved without a baseline level of equity to access. So I do think this gives us an opportunity to really go into the communities in a way that doesn't require patients to come into the four walls of a clinic or a healthcare institution. We can get to people. And granted, not everyone is going to be able to have a telehealth or a mental health visit. Because of their acuity, they might have to come in, and other services or treatments have to be done in the setting. But I think where that opportunity exists for people of color, we're prepared to go in. And I think what the last 9 months have demonstrated is that you have providers with experience, with capability, with capacity and willingness to do that work. And so hopefully we, especially as it relates to communities of color, to be able to get to them and not have to rely on them having to come in, or to Dr. Wanda's point, the transportation issue and just other barriers that are there.
Really good point. So, and I want to kind of interject here because I see a question from the audience that I thought was, it's actually directed right at Aunt Martha's. If you want to sign up for a telehealth appointment, do you have to see a general practitioner first, or is that something that you need to, and Leah, I think you might be able to speak to this too, but do you need to see a general practitioner or a primary care provider before you get a telehealth appointment?
Well, I want to have Dr. Parker answer it specifically, but I would just say philosophically from our standpoint, the care, and this is maybe the opportunity that is in front of us going forward. The biggest challenge with healthcare is that it's not integrated. There are a lot of us that see the same patients for different services, but we're not talking to each other. And that presents a challenge because often we don't know what's happening with the other provider. And so the fact that telehealth can eliminate or mitigate the silos is a big deal. And I think it's an opportunity that allows us to advance the integration of healthcare. I'll point to the DCFS population, which I would argue there is no more vulnerable population in the state of Illinois than DCFS youth in care. And our great colleagues at Meridian or Youth Care, the managed care plan, are trying to create a system that not only care coordinates for these young people who are vulnerable, but also builds a integrated care system. Now think about what telehealth can do when often these children are moved from one placement to another, and it's not as easily for them to remain with their provider. In a telehealth or telemental health world, that doesn't become as much of a challenge, and you maintain the continuity that I think is so important for serving that population. But to answer your question specifically, I'll defer to Wanda about whether they need to come in and see a PCP or a family physician or a pediatrician. Generally, I think we'd like to do that to integrate the care, but if not, we will get to the PCP so that the care is integrated, because it doesn't necessarily all have to happen in Aunt Martha's roof, but we want to be able to work with a provider that is willing to integrate the care. But go ahead, Dr. Parker.
Yeah, that's exactly true, because again, in our integrated model, primary care can also treat behavioral health conditions. And so they may not even need an additional appointment for psychiatry. It may all have been remedied with primary care and then go on to therapy. We also do consultations, and so on the same day that they see primary care, they can also have a behavioral health consultation from a therapist through telehealth as well. Traditionally, we did that in person. So, I mean, there's a benefit for that integrated model. I have a patient that I see who told me that he was surprised that we all talk to each other, that we talk to the primary care, that I talk to the psychiatrist about them. It's like just me. And so I think that kind of individualized care where they feel important and not a number amongst the team, because people who have chronic medical conditions and behavioral health conditions, you need the providers to be talking to each other and collaborating. Yeah. And so that's very much our model, to do that so that we can really wrap around that patient to get better holistically.
Yeah. So I want to, start talking a little bit about the future. And again, I think keeping our lens of increasing access and also equity. So eventually the pandemic's going to end, and people will slowly go back to doing things in person. And I'm going to open this up to whoever wants to start, but I really would like to hear everybody's perspective on this one. What does telehealth look like in a post-pandemic world? Are we looking at more hybrid models for delivering care? Have folks heard about innovation that we should be looking forward to? What are your thoughts on that, and how could folks speak to that? And I'll open that to whoever wants to start and kick us off on that.
Well, I'd say from my perspective, I think we'd really be remiss if we didn't look at the data that we've collected throughout these months. The no-show rates and cancellation rates decreasing, the access to services being more accessible, and so thereby more engagement. Being able to collaborate with multiple providers. If we didn't look at that and we ignored that it happened just because there was a pandemic, I think that we really would be neglectful of the patients that need those services and still have barriers pre-COVID, during COVID, and post-COVID, as it relates to transportation and really even some of the barriers of stigma, being able to reduce that and having easy access. So I think we'd be remiss if we didn't take a look at that need that exists outside of the pandemic.
And let me just build on that, because I think when Dr. Wanda references the data, I think what's going to be interesting to look at is, whether that's a year's worth of data or, however long it ends up being, which even before the pandemic, us as providers have the responsibility to demonstrate to whoever's paying us, is the patient getting healthier in our care? So that standard should not change over the last 9 months or however this period goes on, to look at the data to see if people actually got healthier in our care using this methodology. Will be interesting to see as it compares to, previous years of experience for that particular patient, or, if you're talking about population management, your panel of patients. That's the first thing. The second thing is the cost of care being reduced as a result of using this methodology? And I think it was Representative Conroy who spoke to those opportunities being there as a result of using this approach. So when we talk about data, let's look at those 2 points. Are people getting healthier in our care? And I think that's something that we're all challenged with to demonstrate. As a result of being paid to provide care, we have that responsibility, and we still have that responsibility over the last 9 months. And then 2, are we reducing the cost of care as a result of using this methodology? And I think that's what's exciting as well, is to see what that data shows us when we're at that point to really study it. And I think we can start now. I mean, we have 9 months worth of data to see, how impactful this has been.
Yeah. That would be very, go ahead.
Sorry, Mo. I think from a legislative perspective, COVID has given us or provided us with a perfect storm of opportunity. So we have data, we are increasing access, we are decreasing stigma. This is an opportunity point for us. We've been fighting for telehealth for the last several years. We've been fighting for parity. We now can show, and we have the proof that this is making a huge difference in access. It's also has shown us that we have a better opportunity for wraparound care. It's a huge opportunity for us in terms of continuum of care for our patients. So I think legislatively we have to fight and will fight, and I know that Representative West is on board with this as well. We are going to do everything we can to make sure that the executive orders that were put in place by the governor become permanent. You know, we have, and I think we have a coalition of all different members that have come together through this crisis that are going to be able to provide us with the information and the data that we need to show the insurance industry and the administration, our governor, and our colleagues in the House and Senate just how vitally important this is.
That's exactly what I was going to say. I truly believe it'll be truly un-American for us to go back to the way things were before this pandemic. We have to evolve. And this is one way that we can definitely evolve when it comes to healthcare. So that's, in spite of, I understand of everything that we've been going through these past 9 months, but that's one thing that excites me that's coming after we come out of this pandemic, the things that we can do to redevelop the way we operate. And I'm looking forward to working with you all, understanding the data, getting the data from you, and then sharing it with our colleagues along with Leader Conroy on making sure that Illinois at least comes out of this on the right side of history.
And I just want to add to what Representative West is saying, and I think actually Representative Conroy mentioned this. IHA is working with the Coalition to Protect Our Telehealth, which is a diverse group of nearly 30 Illinois healthcare provider and patient advocate associations who have really prioritized these positions within the goal of urging the General Assembly to protect innovative telehealth approaches developed by Governor Pritzker's administration. And you know, the goal is to ensure Illinoisans can continue to safely access critically needed, quality, affordable care beyond the pandemic that they're already taking part in. I guess in terms of where the future is going, I think, you know, Representative Conroy talked about maintaining components of the executive order, but specifically, you know, patients in underserved communities should not be required to use a separate panel of practitioners or providers to receive telehealth services, which they were in a lot of cases, if it was even offered for plans in the past. Patients shouldn't be required to prove a hardship or access barrier in order to receive telehealth. But and then, you know, I think someone may have mentioned this, it may have been Raul, but conditions, treatment limitations, and requirements like utilization management criteria or extra documentation should not be more restrictive or stringently applied than those established for in-person services. So by that, I mean state-regulated public and private health plans should not make it more difficult to access telehealth than in-person care if you're delivering the same service. So all these variables are important with fair and equitable coverage and payment, creating the most immediate access. And if we can, you know, if the Illinois General Assembly can find a way to develop permanent telehealth access through an equitable lens, I think it would just create, such an advancement for Illinois when it comes to healthcare access.
I think too, I just want to add to that, as in the Mental Health Committee, we're looking to all of you too, because we know that there are unintended consequences that have come out of even the telehealth expansion. It was just recently brought to my attention that we have an issue with long-term injectables, and we need to fix that in terms of allowing our pharmacies or our pharmacists to get reimbursed for doing that. So little things like this that we need to look to all of you to let us know that we need to make sure that we fix, because again, this complements telehealth, you know, fixing the long-term injectables, and continues to provide access to care.
And that's actually a perfect segue to my last question for today, and this is for Representatives West and Representative Conroy. What can the average person do? Not necessarily people who are legislators or advocates or providers or creatures of Springfield or DC, but what is a normal person who wants to advocate, maybe on telehealth, but maybe just on general MHSUD issues do this session, particularly given that it's going to be a unique one because of the pandemic?
Call us. That's what we're here for.
Fair enough.
Yeah. Our best ideas, and I'm new to the legislature, but I've learned that the best ideas that I can come up with, the things that, like you called me earlier, mental health champion. It was because I picked up the phone and talked to constituents, and they told me what was important, and I capitalized on those ideas. And so it's like I can't say that I did everything myself. It's a team effort amongst those who we represent. So call your representatives, call your senators, let them know what you're thinking, let them know what ideas you have, and then we can take that to Springfield, because that's our sole mission, that's our sole job when it comes to representing you.
I think just to add to what Representative West said, he nailed it. But even before that, what I've learned since I first got here and how I probably followed this path to where I am today is by talking about it, encouraging people, please talk about it, talk about how you're feeling, ask how other people are feeling. You know, those conversations are how it all starts. We have an issue, we want to fix it. Okay, we have this conversation, now let's call our legislators. Know that you can make that difference. And through talking about it, we remove stigma and we encourage people to, to move forward in their own personal mental health, well-being, and care.
So with that, we are now at time, so we need to wrap it up. Thank you everyone for joining us today, and a particular thank you to our panelists for this great conversation. For all the attendees, you will receive a follow-up email in the coming days, and we'd appreciate your feedback. And you will also receive in that with a link to a recording of the webinar. My contact information, if you could share it, would be up on the screen right now. But regardless, you'll receive an email, so don't hesitate to reach out to me if you have any follow-up questions from today's program. So again, thank you to everyone for joining. I hope you all have a great week and a happy holiday season. Thank you so much.
Thank you all.
Bye-bye, everybody.
Thank you.
Thank you.